Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome. This is Richard Hazel. Thank you for listening to the Acupuncture Outsider. Today, I'm talking about the longissimus thoracis and mid-back pain from the longissimus thoracis. Now, I'm guessing a lot of people don't know much about this muscle and are probably missing this muscle when someone has mid-back, especially in that interscapular area, that kind of pain. I feel like this gets missed a lot. And when I'm in acupuncture forums, I can't remember ever seeing anyone talk about longissimus thoracis pain. So I see it probably a couple times a month. And I'm wondering if maybe others are just missing it and choosing to use something like cupping or gua sha because they couldn't get the pain to go away with what they thought it was. My guess is a lot of people are trying to muscle test their way to figure things out and are not aware of this muscle. So they're probably doing either a rhomboid muscle test or they're doing some lower trapezius muscle test, and they're concluding that it's a rhomboid or lower trap or both that are causing this mid-back pain. But I want to talk about the quality of this pain because it's important. It's one of the muscle pains. When it's a trigger point, it can be nonstop pain. It can be a pain that the person cannot find a position where they don't have that mid-back pain. It's almost always on only one side when it's a trigger point. So, well, let's just talk about the anatomy. The longissimus is aptly named because there's a part of the longissimus that is in the cervical area and ends right behind the mastoid area. It follows down along lateral to the vertebrae. The longissimus interdigitates a bit with the transverse processes. There's some fascial connections to the lower rib, ends of the lower ribs. And it follows its way into the low back and down to the sacrum, where the erector aponeurosis attaches to the sacrum and helps to stabilize the SI joint. The middle part of that is called longissimus thoracis because it's the thorax. The muscle is an erector, so it helps you to come up from a bent over position into an upright position. It's my opinion that it's a major contributor to your posture. So as the longissimus weakens because it's tight, it may allow for more increased kyphosis in the mid-back. The longissimus helps lateral stabilization. If you have to carry something heavy on one side, the opposite longissimus will tighten to protect your torso from leaning in the direction of the weight that you're carrying. There are other muscles involved, of course, that keep that from happening, but longissimus is an important part of that. The QL on the same side, the obliques, the core like transverse abs will have to feed forward with contraction to stabilize your core while you're doing that. But just know that when you raise your arm on one side, the longissimus on the opposite side is going to help stabilize your spine so that you don't bend toward the side of your arm that's being abducted. So, this muscle, in my opinion, gets injured mostly from things like that. A unilateral carrying, maybe you have to carry a heavy briefcase or a heavy suitcase, and eventually that opposite longissimus can get tight and painful. It doesn't necessarily have to have a trigger point to be painful. It's with the trigger point that it's going to be constant pain. When there's no trigger point and it's just some hypertonicity from slight injury or overuse, then it will be achy. But you'll have patients who are having this mid-back pain, and they could also have rhomboid and lower trap issues. So you have to press on the longissimus thoracis to determine if it's giving them pain, because they could have several muscles that are involved in that mid-back pain. And this, you should palpate it all the way down to where it turns into the lumbar part, just to be sure that you can really hyper focus on where it's hurting. This, unfortunately, is such a dense muscle that it usually needs more than one treatment. It's going to need 1 to 3 treatments, even if there's no trigger points, because it's just such a dense muscle, and it's in a location where you have to be super cautious to not go deep and into intercostal and lung space. You have to be very cautious over this area. So you could feel this dense muscle and assume that it's deeper than that, it's thicker and deeper than it really is. You really need to be very cautious. I needle this muscle usually either if it's just a motor point, then I'm needling it fairly superficially, and that I might needle perpendicularly or at a 45-degree angle, sort of caudally. But if I have to dry needle it, then I'm going to go really obliquely, and I might try first to do it in a caudal direction, and then if I need to, if I really think it's not releasing well, I'm going to try a cross fiber in a medial to lateral direction, so sort of taking into consideration how the ribs curve, so that I'm needling away from the spine to help avoid going into intercostal space. I feel like if you're needling toward the spine or the vertebra from lateral to medial, you're more risky because of the intercostals. But it just has to be done super cautiously. I'm not recommending you try this from listening to a podcast. You really should learn it in a hands-on situation. But this is a muscle that like I said, can be very painful for somebody when it's a trigger point. Now, when I see it causing pain, it's not always a trigger point. Sometimes it's an overuse injury. I'm thinking of one guy who does a lot of manual work and pulling cables for telephones and computers, and has to spend a lot of time kind of crouched over, holding himself up. He's not able to rest on a hand. He's working with his hands, and he's bent over. So those erectors are working really hard in his mid-back, and that can get a little bit irritated. And when that happens, then I'm using just the motor point with electric stimulation for 10 minutes. Now, the people I've seen with trigger points, this is usually something that's been hypertonic for so long that now it's formed trigger points, and then that trigger point can become hyper irritated, and they don't always know why. They don't always have an event in mind. It can be an insidious onset, but it's usually only one-sided. Now, interestingly, on your female patients, you may find this this soreness, and it's usually is one-sided, but you'll find this soreness it can be in the upper mid back area between the shoulder blade and the spine, that mid area. But very often, interestingly, on women especially, you'll find this pain in the longissimus thoracis just below where their bra would go or does go. And it's my theory, especially if you do see it bilaterally, that it's women with larger breasts that are having this pain because the longissimus is working harder in that area. It's like it's an axis that will cause them back pain, mid back pain. And now that I've told you that, you're going to spot it because it's not that uncommon. I really do think I see this at least twice a month. New fresh cases like a couple times a month. Once I've treated it, it usually stays away. I saw this happen to a yoga instructor. She does a lot of handstands and things like that, and not activated it. I've seen this on people who have a physical labor job. But I've also seen it on people who had no explanation whatsoever for why or when it started hurting. But you're going to find it by palpating. There's not like a reliable muscle test for the longissimus thoracis that's going to say, oh, this is what your problem is, without having to put your hands on the patient. So you muscle testing purists, if you're not relieving someone's mid-back pain and you're just cupping it or doing some gua sha, you're probably missing the longissimus thoracis because you think you should just muscle test everything. And you do have to put your hands on people who are in pain to understand things. There's a lot to be said for putting your hands on muscles that you already have tested, because you're gonna recognize a hypertonic state in the pain side. And when you get really good with your hands, you don't even need to say muscle test a QL issue. If you can push your thumbs on both QL and you feel the hypertonic side, you can ask the patient, is this the pain side? You're always going to be right. Hypertonicity is an important thing to feel for. Gluteus medius, very common. You're going to find all those taut bands that are causing them pain. If you're just a muscle testing purist, they may be testing weak, but you're missing the taut bands that are causing their low back pain or SI joint pain, or sometimes even a sciatic referral. You got to put your hands on your patients. Same thing with piriformis. Same thing for the low rotators like the gemelli and the obturator internus. You should, even if you already muscle tested and they already told you that they have sciatica, put your thumb on those muscles and confirm for yourself how hypertonic it is. It gives you a good sense of how much work this is going to be. You should be feeling it after treatment. You should be pushing on all those sore spots again and talk to your patient and get feedback about how does it feel now. A lot of times they say it doesn't hurt at all. Sometimes they say, oh, it's still sore or it still hurts. And you can say, is it different though? Yes. And then you're going to say, is it more of a dull sore or is it still biting sharp pain? And if they say dull sore, that's a great thing. That means you've deactivated the pain there and it just has some inflammation that's going to clear. If there's still some pain there, there's probably a taut band and trigger point, and you're going to decide between you and your patient if today you're going to deactivate that trigger point, or if you're just going to wait till the next time they come in. But putting your hands on your patients is essential. So when people say, oh, you shouldn't need to palpate, You should know the orthopedic tests and use your observation to diagnose. Well, you should, of course, observe. Of course, um, it's great when you can spot an inconsistency in movement patterns. That's a given. You'll see that when they come in the door. I have a very long um, waiting room that goes back to my main treatment room, so I get to watch my patients walk in, and I'm always looking, especially if I already know the patient and I know what I'm treating. I'm always watching their gait. I'm always getting a sense of, how they're moving without asking them, and then I'll ask them, based on what I see. Sometimes a brand new person comes in, and based on how they're walking, I might ask them, "Are we working on your hip today, or is this a back pain issue?" Um, so obviously, observation is essential. They said Vladimir Yonda could sometimes diagnose somebody just by watching them. And, I totally get that. But once you have an assumption about what's going on, there's nothing wrong with putting your hands on your patient and feeling. Carl Levitt was big on that. He wanted to palpate everything. And then he said, I think there's a video I saw on YouTube where he's saying, and once you put your hands on your patients to palpate and feel for the muscle tension, you will be called unscientific. But Carl Levitt wanted great results for his patients more than he cared about what his colleagues thought about how he assessed the issue. Most of our doctors don't even want to put their hands on you. They don't even want to hear from you. They just want to see your results. They want to see the report from your MRI or your X-ray or your blood work. They really don't want to hear your opinion because that's bias. They really don't want to put their hands on you. And I think a lot of them just wouldn't even know what they were feeling for anyway. But that's the difference between the people who are getting results and the people who are just being dogmatic and insisting upon this sort of rigid idea of how you assess pain. And muscle tests are great, and I use them, especially for things like shoulder pain. But do I test the glutes regularly? No. I'd rather just push my finger in and tell you what's going on. Do I muscle test a lot for, say, TFL or gluteus minimus? No. You already told me what your pain is and what you're feeling. I already know that I'm going to treat those muscles. And when you're on your side, I am going to confirm that they're hypertonic, or you're going to tell me that it's painful when I push on them. And we're in agreement. That's what we're treating. So I may be a little unorthodox, but I get great results fast, and I have great assessment skills. And a lot of that is observation, talking to the patient, asking for pain referral patterns, asking what positions they don't like, what makes it worse, what makes it better. And then I'm going to put my hands on the muscles that I think are a problem, and I'm going to confirm that that's what we're doing. The coracobrachialis in the front of the shoulder is very difficult to isolate in a muscle test. It's a lot easier to just push your thumb on it and see if it hurts or if it feels super tight, because it's going to look like a positive for infraspinatus muscle test when it's really the coracobrachialis. So it's going to look like they're going to say anterior shoulder pain. You're going to say, oh, infraspinatus. And that's happening to so many people. And of course, doctors, they're mostly thinking about rotator cuff because that's where the money is in rotator cuff surgery. There's no shoulder doctor who's worried about your coracobrachialis. So they are, of course, going to miss that and tell you have an infraspinatus injury. And then, you come to see me and I feel the pain in the coracobrachialis. We treat that in 1 or 2 minutes. And then we retest. And then if there's no pain and you're strong, I'm not worried about your infraspinatus. Now, I'm probably going to palpate your infraspinatus and see if it's super hard or painful. Do you have tight bands in there? Do you have painful taut bands in there? Okay, that needs to be addressed. That definitely can cause anterior shoulder pain. But so many people have brachialis injuries that they're being told it's rotator cuff. I saw a patient this week who had second degree burns all over his upper body from an accident, explosion of like diesel fuel or some sort of gasoline or diesel something. So that was a long time ago, and his skin didn't look burned at all to me. And he told me what he did was some sort of herbal thing that helped heal it, and the doctors were shocked. So so he gets burning in his forearms, and he assumed it was because of some sort of neuropathic pain from the burns. But the burns were a long time ago, and the burning in the forearms is fairly recent. And so, of course, I palpated his coracobrachialis on both sides, and they were hypertonic and sore and painful. So I explained to him it's very likely it's the musculocutaneous nerve that is that innervates. That's the cutaneous nerve of the forearm that is irritated by the coracobrachialis. So we're going to treat the coracobrachialis and see how it goes. Now, I haven't seen it for a follow-up, so I can't tell you if I was exactly right, but I'm pretty sure that it wasn't from being burnt. It was tension on the musculocutaneous nerve that was causing that burning in the forearm. But pushing on the coracobrachialis is my favorite way to assess it. Sorry if that's not impressive to anybody, or, the people who want to teach muscle testing for everything. I don't need the muscle test. I want to feel if it's hypertonic and if it's sore. So I guess that's I already talked about longissimus thoracis. Start looking for it. You're going to find it. You may have been thinking that it was something else, and you may have been getting frustrated that your motor points weren't working for this person's mid-back pain, and you might have just been missing the longissimus thoracis. So start palpating for it, and that's it for this week. Have a great week.